Okay, this is biopsy proven case.
EHE.
Good. Yes. Yes. Tell me about a hepatic hemangioepithelioma.
It's usually younger females, peripheral, targetoid, multiple lesions, can be indolent or slowly progressive. And
So these are the delays. So this one's
yeah, they have the like opposite hemangioma look where they
yep. Okay.
like have this central enhancement and then peripheral. And actually they have a peripheral T2 hyperintensity, right? Oh no.
Yep. Look at this.
Okay.
Isn't that beautiful?
Beautiful. They also have what is called the lollipop sign, right? There's a
what's that?
The dome or the ball of the lollipop is the lesion itself, and then there's a vessel going into it, which is the stalk.
Oh, wait. So
On
dome
post contrast, if you have a post,
yes.
If you pull it up, let's see if we can see it. Basically, they have a vessel going into them, which is set
Like this?
present.
Okay.
No, I think if you go back right there. I don't know. I think it looks like it.
Let me get an arterial. Maybe that'll be better. I don't know.
I'm not sure if it's the artery or vein they allude to, but they say that there's a vessel feeding that lesion, which represents the stalk of the stem of the lollipop, and then the lesion itself, the rounded part, is the candy.
Okay. Well, I'm going to hallucinate that this is the lollipop stick.
A horizontal.
Maybe. Yeah.
Anyway.
So where's my yes, so these are like AIRP cases from radiographics and some of the features that we can see with it. So this was MR, so I'm going, they're subcapsular location, they're usually multiple. And you can see there's like a T2 halo, like Arthi you had already mentioned. And
actually,
lollipop sign?
But even there's an even brighter central T2 part and then a T2 like intermediate halo.
And they can cause capsular retraction, like we saw in my case. And these are just some path specimens. So I thought this was just a really nice case of classic appearance of.
And one thing I'd like to add as well is we've seen a couple patients who developed Mets to the lungs, and the Mets were like miliary TB. You know, they were very tiny, like few millimeter sized metastatic lesions throughout the lungs. I don't know if that's a typical feature, but in both those patients, we saw Mets that looked like it to the lungs, and they were very indolent.
Really, if you if you scroll up, I think so you're in the hepatic epithelial EHE, but there's also pulmonary EHE. So it's interesting what you say, Anu, like that they were Mets, because there's also like a pulmonary EHE that's, I just wonder if like they're truly Mets or they're just kind of the pulmonary manifestation of the same thing.
Yeah.
But anyway, they say there are usually multiple nodules, bilateral, random distribution, usually 3 millimeters to 2 centimeters.
Yeah. They came much later than the liver lesions, so we automatically assume, but they could be concurrent, the same entity.
Yeah, and we're following a whole bunch of patients that have hepatic EHE, and it seems like a really variable distribution, like a progression. So some of them have been totally steady, some of them have just spontaneously started involuting, and others have been progressive. And when they get progressive, they start thinking about transplant. So it's really, you basically just kind of have to follow them.
Yeah, and that's why this patient came to our attention for evaluation of transplant. And that is a treatment option for patients with bilobar unresectable disease.
There, Anu, it says metastatic lesions are reported in 30%, occur most commonly in the lungs. So
cool.
Yeah. So this is a patient that came to the ED age is immaterial here. And I'm going to scroll through the axials first. They came in with acute abdominal pain. They behaved like a surgical abdomen, and you can see why. There are some dilated small bowel loops here. And as you continue looking at the right iliac fossa, you'll see that there are foci of extraluminal air and what looks like perforated appendicitis. So indeed, they presented as acute appendicitis with perforation. Now, the radiologists who read this were very astute, and the entire credit goes to them. So not only did they recognize that there is perforated appendicitis, you can see an appendicolith here, but they actually also picked up a lesion in the sigmoid colon, which I thought was remarkable. And I'm going to show you the coronal and sagittal planes as well. Let me window this. So this is, an abscess in formation, free air, and the sigmoid mass itself is in this region. It's hard to see in the coronal plane, but I thought you could see it better in the axial plane.
Yeah, and actually in the coronal, like if you go from there forward, like you can see how thin the wall is, and then there it gets like a little ill-defined, but it is a really great pickup, especially because you could easily have like satisfaction of search here, like, okay, there's a bowel obstruction, there's a ruptured appendix. One point I want to make is like, see how that terminal ileum is thickened, and there's the obstruction. So sometimes people just kind of like forget about that this is all just reactive to the appendix and say like hedge on like Crohn's disease, which, there could always be Crohn's disease, but like more likely it's a ruptured appendix with reactive thickening of the adjacent terminal ileum.
Okay. Excellent points. So they went to the OR, they removed this mass as well in the same sitting, sigmoid mass. And before that, I think they did a colonoscopy. I'm not 100% sure, but this did come back as sigmoid adenocarcinoma, and it was through and through the wall. But there was another very interesting finding, and that is the reason why I'm showing the case. So let us go back to the coronal plane. And I'm going to point out, let me move the box just a little bit. So now if you focus on the appendix, here is where the appendix attaches to the cecum. And if I window this, there is an enhancing lesion within the appendicular lumen. I don't know if you can see it right there. And this we are assuming this is what caused obstruction. And then the dehiscent wall of the appendix is distally. So basically they saw a met from the sigmoid colon. This was a metastatic adenocarcinoma to the appendiceal lumen, and which we are assuming caused the appendicular perforation. So I haven't seen, mets to the appendix from colon cancer. We see so many colon cancers in all places, like cecum, ascending, left colon. But this is my first instance of seeing a met to the appendix causing perforation. I don't know if others have seen it. I looked up literature. There are case reports where they talk about mets to the appendix from cecum or ascending colon. I didn't find such a distant colonic primary causing appendicular mets. So just thought this case was very interesting. And, again, as Aarti alluded to, satisfaction of search was not the case when they rightly found the sigmoid mass.
Okay, just to play devil's advocate, how do they know it's a MET versus just a primary appendiceal adenocarcinoma? Because I feel like path reports always just say like adenocarcinoma of GI primary.
Yeah, no, I think because when they resected the colonic, they were very confident in, I don't know the path background of why they were confident, but they were very confident. And in the report, they said it's metastatic to the distal appendicular lumen with perforation and, serosal lesion, tiny serosal mets as well. So I don't know how they were confident, but
so it was like a serosal met. So like it looked like it was more coming from the outside than like arising from the mucosa.
There were concurrent serosal deposits as well as to the lumen.
Okay, that makes sense.
Yeah, they specifically said that distal lumen appendix, and there were micro mets on the serosa as well. Plus, at the sigmoid primary, the mass was through and through, and in the surrounding fat adipose tissue as well, there were micrometastases.
Got it. Very cool.
Yeah, so that is my first one. And then we can go to the second one straight away. So I'm going to start with 4 time points. This is the first time point. As you can see on this CT, there are bilateral pelvic side wall metastases from a new diagnosis of prostate cancer. And then if I go on to the bone windows, there were some osseous metastases here as well. So they were diagnosed as prostate cancer, metastatic to the bones, and they were being treated, and this was a conventional prostate adenocarcinoma. They were being treated with androgen deprivation therapy. And this is another time point where you can see that the primary prostatic mass itself is smaller in size. There is some sclerosis, increased sclerosis within the osseous metastases. Some of them look larger, but the rest of the lesions in the spine looked more sclerotic, and they were responding to treatment. And then a couple years down the line, this is what we noticed in the follow-up scan. You can see that at the site of the primary lesion itself in the prostate, there is a mass that has increased in size. And if I go on to the bone windows, you see that there is a new soft tissue associated with this left hemisacral met. So given that they were doing so well on treatment, and now this scan this time shows not only that the primary has increased, but there is increasing soft tissue within an osseous met. This was biopsied. And any guesses what this might have come back as? Not.
How many years after radiation?
They didn't get radiation.
Oh, no radiation.
No, they were on hormone androgen deprivation treatment. No
Could it be neuroendocrine?
Exactly. You're absolutely spot on, Malak. So this was neuroendocrine dedifferentiation of prostate cancer. In literature, I actually found this interesting article, and I'm going to try and see if I can move my window here.
Someone else showed like a neuroendocrine dedifferentiation of prostate here, and that was the first time I'd heard about it. Was it you, Nelly?
I vaguely remember the case, and I don't remember if it was me, but I do remember us talking about it.
Yeah. Okay, cool.
So here it is. This is a 2018 article. There are many more articles, but this article states that the incidence of aggressive neuroendocrine prostate cancers related to androgen deprivation therapy is rising. This is without going into all these molecular details. It is good to keep in mind this entity so that the patient can be biopsied appropriately if lesions that have been responding suddenly go berserk.
So these are arising from patients who had ADT?
Yes, who have been on ADT for some time, and this is neuroendocrine differentiation. I don't know if dedifferentiation is the right word, but differentiation of the same adenocarcinoma. And
these obviously probably won't be expressing the typical PSMA and,
Yes.
I mean, like if we were just following biomarkers, the patients would be NED, right?
Correct.
So imaging is really the only way to identify them.
Yes, absolutely right, Nelly. That's the second point I was going to bring up, that because of that point that you mentioned, the PSA is not a good biomarker. It doesn't rise in these patients. And so, CT or MR or whatever way we are following them is the way to suspect that this might be the case if the mets increase in size or the mass increases in size. Unfortunately, these can be very aggressive, as you can see here. So let me stop sharing. Someone else can present.
I have a question, because like when we talk about enlarging, we talk about using PSMA PET MR or PET CTs for prostate recurrence.
Mm-hmm.
And then we talk about dotatate for neuroendocrine. So if the PSA is not rising, but the mass is enlarging, is that a situation where you would say like maybe do a dotatate or?
I think these are neuroendocrine carcinomas, not neuroendocrine neoplasms, whereas the pancreas mostly has well-differentiated neuroendocrine neoplasms. This is a neck, not a net. So it's a carcinoma.
Oh, got it. So it
Most
won't
likely.
be dotatate positive. It'll be like
Probably FDG would be better off.
FDG, yeah, that makes
Yeah.
sense. That's a good point.
awesome. Okay.
So this was a young female who presented with the lightheadedness and abdominal pain.
Hemoperitoneum.
Yes, large volume hemaperitoneum.
An active extravasation from the right adnexa, like maybe an ectopic or a hemorrhagic cyst.
Exactly. So this was a ruptured ectopic, which we see all the time on ultrasound, but I've never seen one on CT. And this was a double phase arterial and venous. So we see here markedly very vascularized right adnexa that's actively bleeding into the cul-de-sac, and a large volume hemaperitoneum. She was rushed to OR and she had a ruptured ectopic from the right that was actively bleeding actually.
And I assume she got a pelvic ultrasound first, right? Because probably her HCG.
Well, she was transferred
Okay.
from an outside hospital, so I would assume the ultrasound was done outside, but we never got an ultrasound here. They were concerned for like ischemia, like bowel ischemia or other things. That's why they got the CT.
Got it. Because if her HCG was up, usually they don't start with a CT.
With a CT, yeah, good point. So I'm not sure why they just started with the CT. She was transferred, so there are some missing pieces of the history.
Yeah, that's a lot of active extra.
Yeah. So this is this one. Let me show another one. I'm gonna stop sharing.
Go.
So this is a 60-year-old male with pancreatic cancer who presented with the active GI bleeding. And this
Why is there
the-
contrast in the CBD stent?
Exactly. Why is there contrast in the CBD stent on the arterial phase? So we have a
Could we
non-con.
traverse it?
So there's a non-con, it wasn't there.
Like
There's the
fistulized
arterial.
with the hepatic artery.
So it has eroded into the hepatic artery, and there's a pseudoaneurysm from the hepatic artery into the CBD because of the irritation by the stent. So this is a pseudoaneurysm from the hepatic artery, kind of protruding into the stent. So IR
Wow.
went in and embolized it actually.
That's a great pickup and finding. That's awesome. Can you show the arterial? Like, I feel like that would be easy to miss on the axial or in general. Because, you know, those stents, like, you know, you don't necessarily like.
We did not
scrutinize.
actually call it prospectively. We just said like it is very close to the hepatic artery, but we didn't call it pseudoaneurysm because we weren't sure what's going on. But then IR went in and then they embolized. They said there's a pseudoaneurysm there. So this is a 40-year-old male who's presenting with abdominal pain. And if you look in the lung bases, you might think that he has something going on there. Some bronchiectasis, some three-in-bar opacities, some atelectasis in the lingual and right middle lobe.
Yeah, for a young patient, I would have thought like cystic fibrosis in the differential.
Okay.
And then
How about the
fatty
pancreas?
replacement of the pancreas. Is it?
Excellent. So he does have cystic fibrosis. We were given that history. And we see here thickening of the colonic wall, but it's not decompressed. It's just a thick wall, and it's not actively inflamed because the fat behind it is clear. But there is hypertrophy of the omentum and the mesenteric fat, and there's some fat stranding around the right hemicolon. And going further down, the appendix is pretty much dilated.
Wait, and was the TI is really dilated too, right?
Exactly. The TI is dilated. There's like some fecal material in the distal bowel as well, and the dilated appendix.
So is it like distal intestinal obstruction syndrome?
Exactly. So this is classic for distal intestinal obstruction in someone with cystic fibrosis.
Wait, I didn't know that it thickens the colon.
There will be colonic wall thickening. I'm not sure why. I think it's just because it's been like a large capacitance for a long time or something from slow transit.
Do you have a coronal, Malak?
Coronal, yes.
So my understanding is like, because the cystic fibrosis, they don't have the proper enzymes, that like the digestion doesn't happen as properly. So then in the like distal small intestine, and I guess probably the colon, it gets it just doesn't transit as well. So it gets like chronically obstructed.
Yeah, yeah. And he had stopped his pancreatic enzymes when he presented. I was looking for steatorrhea. Sometimes we see fat fluid levels in the bowel, but we didn't see that. That's a common thing we see when they stop their pancreatic enzymes because they can't digest the fat anymore.
And this is not a surgical small bowel obstruction.
No, his appendix was actually dilated when he presented a few months back, and they called it appendicitis, but it had hyperdense content. That's all because of the slow transit. So we did not call appendicitis or anything acute here. We just called the DIOS. So this is all this asymmetric mesenteric fat hypertrophy and fat stranding on the right compared to the left.
Do you know where that happens? I don't.
I think, as you mentioned, it's because of the like suboptimal or limited digestion and slow transit.
Got it.
In a way, it's like partial chronic bowel obstruction or just like functional small bowel obstruction. It's not really mechanical.
Go.
Perfect. Okay, excellent. So this is a CT that was part of staging CT chest, abdomen, pelvis, because the patient was diagnosed outside with vaginal cancer and sent to us as part of staging CT. And they came from, regardless, they came from an outside place. And before they came to us for staging, in the interim, they had been seen by a gynonc, and their mass had been biopsied as well. So here is the mass, and we didn't see any other metastatic disease in the abdomen. And then the mass, however, was causing right urethral obstruction. And as you can see, there is right-sided hydronephrosis. Now, I happened to read the CT, and one thing that struck me was throughout their notes, they didn't have any vaginal bleeding. They were young. And the reason why they had had a hysterectomy previously was for fibroids. So, without vaginal bleeding, it seemed a little unusual that they might have vaginal cancer. And then the other thing that struck me was when the gynonc examined them and felt this mass, they couldn't see anything on the mucosa, and they described the mass as hard. Here it is in the sagittal plane. They described it as hard. So we asked for an MR, and here is the MRI. This is the T2 axial of the mass on MR, non-fat SAT.
Wow, it's a dropped fibroid.
That could be one. That's a great thought.
Or a leiomyoma.
That's a great thought. And I'm going to show you the T1 now.
Adenomyosis, I'm assuming.
Endometriosis.
Endometriosis, I mean, yeah.
Yes, exactly. So you can see that there are some T1 bright spots here. The ureter is caught. The post-contrast really doesn't help us that much. There is enhancement, and there is restricted diffusion as well, because blood products can restrict diffusion too. So really, diffusion doesn't help us when there are, like, endometriomas can show restricted diffusion. Sorry, I don't think I'm showing you the right sequence. But anyhow, this went to the OR. We prospectively called this endometriosis. They went to the OR, and this is path-proven endometriosis. A few years after fibroid surgery in the vaginal cuff.
And did you look at the path from the hysterectomy? Like, was there adenomyosis there? Because it seems unusual.
Yeah. Well, we didn't, because this was many years back and it was outside, so outside that we couldn't access those records. So we couldn't see it. And the only history they provided was fibroids, no mention of adenomyosis. But then the other thing is any pelvic surgery in women can cause endometriosis by seeding. So they don't necessarily need to have adenomyosis or any benign myomectomy can cause endometriotic implants later on. So we don't know if there was.
Yeah, I wonder if it's higher if you kind of like, I don't know, it seems like unless they morcellated the uterus, if they just did a hysterectomy, like why would the endometrium come out? But, yeah, I see what you're saying.
Yeah, no, but scar endometriosis is one such instance where, even if there is like a scar for C-section and patient does not have fibroids or adenomyosis, endometrium can implant along the scar and give rise to isolated scar endometriosis. So I attended this World Endometriosis Congress, and there one GYN surgeon does a very interesting technique to decrease the incidence of scar endometriosis. What they do is when they do, because C-section is very common these days, when they do the incision in the skin and subcutaneous tissue towards the uterus, they cover the two margins of the incision by some sort of sterile wrap, and they isolate the field of like the margins of the scar. They isolate it by covering it, and they presented a paper where the incidence of scar endometriosis is less in these women. So I thought that was very interesting.
Wow, that's super cool.
Yeah. All right, here is my second case or fourth case. So this is a lady who presented with hematuria, and she had a hematuria protocol CT done. And the CT was reported as negative, no stones, no solid enhancing renal masses. Here is the bladder. They didn't see any bladder wall mass. A year later, they had hematuria again, gross hematuria. And now they saw something on physical exam, and which prompted a pelvic MR. So do you see any abnormality on the SAG T2 pelvic MR?
There's intermediate signal intensity over the mid urethra there. Yeah.
Okay, excellent. I'm going to show you an axial T2 through the same region.
Wow. Is that carcinoma within a diverticulum?
So not within a diverticulum, just a urethral. Well, it could be in a diverticulum. At this stage, I mean, the shape of it, it was just reported as urethral carcinoma, but it could be in a diverticulum. Reason being, I'm going to take you back, and it has all the.
There was a tiny fluid signal dot on the CT from last.
Excellent, exactly. Yeah. So I was going to take you back to that to show you that gross hematuria, we have to look in all possible places. But, this shows typical features of an ugly looking mass in the urethra. And so if we go back to that CT and look carefully and window it, yeah, you're right. It could have been a diverticulum at that point because it has that configuration, crescentic periurethral hypodensity in that region.
Do you know what the path is? Because usually in diverticular, you get adenocarcinoma, whereas if it's de novo from the urethra, it's either squamous or urothelial.
Yeah, they called it transitional cell. But the other thing they also said was the bulk of the mass was beneath the mucosa. They could see only a small portion of mucosal abnormality, but the bulk of the tumor, they said, was beneath the mucosa. And despite that, which you might think might be from a diverticulum and adenocarcinoma, but they called it transitional cell carcinoma. So just interesting. Gross hematuria, do not miss out this region. And we didn't have an MR here. So based on the resolution of the CT, it's hard to know if something was brewing at that time itself. It's hard to know.
I do think urethral diverticular are missed on a lot of CTs. and urethral stuff in general. So it's good to like, just add it to your checklist. And then MR sees it much, much better. And then back to like the path part, I think like the diverticula, the adenocarcinoma is more common, but I think sort of like bladder diverticulum, urothelial in general is like the dominant subtype. So it could still be in a urethral diverticulum.
Diverticulum.
Yeah.
All right. So I can stop sharing.
Okay, this is just a cute one. The patient has gross hematuria. So microscopic hematuria, a lot of the CT urograms are negative because there's lots of benign causes of microscopic hematuria, but gross hematuria is more common to actually find something. So any initial thoughts?
I mean, with these big veins, I'm looking for like an AV fistula or AVM.
AVM or compression of.
Oh, like a nutcracker?
Yes, like a
nutcracker. So definitely not a nutcracker, just because like we can see that the vein is nice here, but if there was the SMA is closer to the aorta and you get that narrowing here of the renal vein, we can think about nutcracker. That usually causes a varicocele, hematuria, and left flank pain. But yes, you guys are on the right track. So the question is like AVM or AV fistula, and what would you favor in this situation?
I'd favor AVM.
Yeah, exactly. So we can see that there is a very large artery coming in, and then there's a big tangle of vessels, which is like kind of the keyword buzzword for AVM, and then a large draining vein. So when you've got that big nidus, this vascular nidus, that's more likely a congenital AVM. It can be seen with like Osler-Weber-Rendu or HHT, and or just like isolated congenital anomaly. AV fistula is usually, you don't get this big tangle of vessels, but you might get early filling of the vein, and it's usually post-traumatic, usually from a renal biopsy or from renal trauma. Okay, so we have one cause for hematuria, and then cute finding, we have another cause here. So if you want to get rid of this kind of layering, you can have the patient do a log roll. Luckily in this case, we could see the filling defect without the log roll, but could have been missed. And so we can see this big frond-like lesion in the bladder. This was actually resected, transurethral resection of this bladder tumor, and turned out to be a low-grade papillary urothelial cancer. They were able to get the muscle, and there was no muscle invasion. So when they do biopsies or resections, like transurethral resection of a bladder tumor, they want to make sure they get into the muscle layer so that they can say that it's non-muscle invasive. If it was invading the muscle, they need to do a total cystectomy, but otherwise they can just do routine surveillance and repeat transurethral resection of bladder tumors. So this was a low-grade one. It was completely resected. It was not muscle invasive. And then incidentally, they also had this this AVM of their kidney. So the AVM was treated with embolization by IR, and I'll just show you the post. And here you can see there's still some filling of that artery, like proximally, but there's a big coil pack in here, and basically the whole nidus is devascularized. So it was a successful coiling of an AVM.
Nice.
Very nice case. There's some infarct or ischemia as well of the renal parenchyma.
Yeah. I think they were okay with, killing off that part of the kidney because they just wanted to like not rupture.
Right.
Yeah. Okay, hold on one sec. Okay, so this patient, ignore this. This was actually a large pseudocyst with some debris in it. Or that. Okay, so that's a little just distracting feature, but I want you to focus on this guy over here. So we've got stomach, we have some debris in the stomach, and then we have this fluid-filled structure.
Is that a feeding tube going into a duplication cyst?
No, good thought. There is this fluid-filled structure, and there is a catheter affiliated with it that goes out of it into the duodenum.
It looks like some sort of misplaced Foley, but the balloon is too large for a Foley. Wow.
Okay, I'll tell you it's not misplaced.
Gallbladder.
No, gallbladder's over here. Okay, so this patient had gone to another country and gotten surgery. And this is what we think what is called a transpyloric shuttle. Can you guys see this?
Yes.
Yeah.
Cool.
Okay, so apparently there's all these different types of like balloons they can put in the stomach. So it's kind of ingenious. Like instead of doing gastric bypass surgery, they put a balloon in the stomach to give you early satiety. And one of my colleagues was saying that like in the US, they've seen this one where they basically just like blow up a balloon and leave it in your stomach. The case I'm showing you, there's a balloon and it has a tube that goes into the duodenum. And this is what's called a transpyloric shuttle. These are all just variations on the same thing. But the reason that they do this is that they actually want it specifically in the pylorus. So they want you to feel early satiety by having like a balloon in your stomach, but they also want to have delayed gastric emptying. So they put it so that it's like basically one part of it is like going into your duodenum. So it's kind of anchored in the pyloric region. Does that make sense?
Yeah.
Yeah. So anyway, this patient got this done in some other country. None of us had ever seen this or heard of this. So it was just really, really interesting. But I had also just didn't even realize that like, you know, people, there's all these different types. Like you can have 3, you can have 2, you can have 1, you can have it specifically located in the pylorus, you know, that kind of thing. So.
Wow, nice. Yeah, I've never seen that. We have a trial going on where we put the gastric balloon, like the middle one that you were showing on the picture, and we do ultrasounds for them to document the position every several weeks.
Oh, wow. Cool.
Yeah.
Yeah. This, I mean, obviously it seems to be working since there's a lot of debris in the stomach, you know, and it does look like the you know, the catheter tubing is going into the duodenum part. So it's kind of in the proper location that they wanted it to be, but.
Is pancreatitis, can that be a side effect?
Yeah, we were
Depending on
kind of trying to
the-
see like, are these related? I mean, it was just
Yeah.
kind of like a weird coincidental thing. They weren't saying it was definitely related, but you know, I could see like maybe if there's, I don't know, something would have to be, you know, obstructing then the
Obstructing,
gut
yeah.
or, you know.
At the ampulla. Yeah.
Yeah.
Nice. Thank you.
I guess
Sorry, what did you say?
pizza and beer could be risk factors for obesity and pancreatitis.
Pizza and beer. Yeah, so these could be
I mean, that's
related.
how they could be related.
Yeah, it's true.
Okay, I can show my last one.
Okay.
Yeah.
Okay. So this patient came in with acute abdominal pain. And here is their CT. As you can see, you start seeing a large solid and cystic mass in the pelvis, lower abdomen, and it looks like it's arising from the pelvis. Uterus is displaced to one side. So this, you know, the usual suspects, young woman, so arising mostly from the ovary. And then I'm looking for the right ovary. This epicenter is on the left. On the right as well, the right ovary itself is not normal. So you're thinking in terms of, so what would your thought process be? Looking at this, there's no ascites, bilateral ovarian masses.
So I guess stroma tumors, if it's such a big lesion with no ascites, but I mean, still surface epithelial tumors, they can be big without
Yeah.
And then Matt's
outgoing
like,
malignant.
Yeah.
Or Krukenberg, yeah, exactly.
Yes, or Krukenberg. So as you scroll through the scan, I'm going to stop right here. And there is another finding in this image.
like a colonic mass or?
Exactly, exactly. Yeah. So along the cecum, you see this polypoid mass, and this is what it looks like in the coronal plane. So this turned out to be a colonic primary with bilateral ovarian mets. So just another, another teaching point along the similar lines. do not wait with satisfaction of search, look around, especially when, in a young woman when there are bilateral ovarian masses. 5 to 10% can be metastases, and the usual suspects are either appendix or colon, endometrium, and then of course gastric, yes. Gastric.
You know, I've had a very similar case to this, and I was shocked at like how big the ovarian mets were compared to the colonic primary. And then I read on, like, I was reading some literature and it said like, you know, that's kind of not that uncommon. Like, I think once it gets to the ovary, it can just like explode in the ovary. And then the other thing that I read is like, if you have a colonic mass and ovarian masses, it's more likely that it's like a colonic cancer with ovarian mets than it is ovarian cancer with like a colonic met.
Agreed. And the other thing is, if it's the appendix, sometimes the appendix can be really hidden because the ovarian mets are so large that the appendicular primary can be completely hidden. And it may be difficult to find it prospectively as well. So that's all. I'm going to stop sharing. Those were mine for today.
So this is a companion case for the CBD stent case. This is a patient with pancreatic cancer again who had a plastic stent that is in good position from the right hepatic duct, goes all the way into the CBD in the pancreatic head and then into the duodenum. And the following month, the patient came for their follow-up, and the stent has been exchanged. It was not exchanged here. I don't have the procedure now. It has been exchanged for a metallic stent, which is still in good position distally. So here it's in the CBD. Here's the gastric wall. However, proximally, the stent is actually in the stomach. So on this part here, this is the gastric lumen. The stent is actually crossing in through the stomach, and it has fistulized the left hepatic ducts, and this is where the proximal aspect is. So this is a choledochoduodenal or choledochogastric fistula because of the metallic CBD stent.
Wow. We see a lot of these stents, and usually they do okay, but
Yeah.
Not always. Okay, I have a quick one. Okay, so there's a finding in the upper abdomen.
Other than the missing kidney?
That's the finding.
Okay.
And then there's a finding in the pelvis. You guys are going to get this.
Oh, nice. So that's a Zinner.
Yeah. So there is, this is Zinner syndrome. So ipsilateral renal agenesis. There's a seminal vesicle kind of cyst, and that's usually due to ejaculatory duct obstruction. So basically the Wolffian system, where both the like seminal vesicle, ejaculatory duct, as well as the kidney are forming from the same bud, and they both become abnormal. So the kidney bud does not develop, and then the ejaculatory duct is obstructed, which leads to the seminal vesicle obstruction and the kind of cystic dilation of the seminal vesicle. And then the other interesting thing is there was this like tubular thing, fluid-filled thing inserting on the seminal vesicle. And so we think that that was actually the remnant ureter ectopically inserting on the seminal vesicle.
Cool.
Yeah, so they call it Zinner syndrome. Usually they just kind of like, you know, it's incidental. It can lead to decreased fertility because of the ejaculatory duct obstruction, and it can lead to symptoms. So in younger patients with symptoms, they might resect this part of it, but usually they just kind of treat it conservatively.
Nice. So this was this is a 39-year-old female presenting with right upper quadrant pain. We started with a CT from the ED, which did not show any cholecystitis, but the CBD was a little bit dilated, so we got an ultrasound. It's 11 millimeters, and she has her gallbladder in place. She doesn't have any hyperdense CBD stones, so we got an ultrasound. So the ultrasound shows that the CBD is dilated.
It's so funny. If that was the situation here, we would go to an MR.
Yes, that's what actually we did. We did that.
Okay.
I think I have. I think when I was putting the ultrasound, it showed the patient name temporarily. So we might need to edit that.
Yeah. That's fine. I can do it.
Yeah, okay. So here's the ultrasound. It shows that the proximal CBD is really dilated. However, distally it was not dilated. There is some shadowing from bowel gas. So the next step was MRI. And I'm going to show the MRCP. On MRCP, actually, the proximal CBD is dilated. The distally it tapers slowly and gradually in normal fashion. However, proximally, the right anterior and the posterior ducts, they have kind of knobbing, and then there's an abrupt transition to normal caliber ducts. So we think this is a type 4A choledochal cyst, actually, because there was nothing else to explain the dilation. What are your thoughts?
How old is the patient?
She's 39.
Okay. I always have trouble with the choledochal cyst calling, because it's like, I don't know. There's no pathologic way to prove it, because the biliary epithelium is the same in a choledochal cyst as well as a regular bile duct. So you could never get full proofs if something was a choledochal cyst or just like a patchel,
Yeah, but I guess the other option is to have focal structure here and a focal structure here, but the rest of the ducts are completely normal.
Yeah.
Very unusual.
It's interesting too. This actually looks like, is there a crossover here? Like the right posterior duct is joining the left duct there, it looks like. See that duct going across?
Or is it more like a trifurcation, maybe? It might be a crossover.
It's either a trifurcation or it's a crossover, because it looks almost like it's crossing over and joining the left. Yeah.
Here's the thin cuts. It is probably a trifurcation.
Yeah. So in these cases, if it's a young patient, a lot of times they'll do like a risk reducing surgery where they'll resect part of the, like below the confluence and then up to the pancreatic head, they'll resect that part of the common bile duct to reduce the risk. And you didn't see an ABPJ, right? Like to say that
no, it was normal. Yeah.
Reflux of pancreatic juices is what's causing this, which is affiliated with choledochal cysts. Cool. Okay.